Trina Monahan. I'm a nurse practitioner on the palliative care team, inpatient palliative care service at Maine Medical Center. I also am one of the selection committee members for the LVAD, representing palliative care for the LVAD selection committee here. I've worked in palliative care at this hospital for a little over 2 years. And several years prior to this at a hospital in Connecticut. And before that, also worked as a heart failure nurse practitioner in Connecticut. So this is a topic that is near and dear to me, and just really happy to be here and talking with all of you today.
Hi, I'm Katie Adicott. I'm also a nurse practitioner here at Maine Medical Center. I've been working here in the palliative care program for 10 years. I don't have a background in nursing and heart failure previous to this, but I've certainly seen quite a few patients with heart failure over the last 10 years and in a lot of different scenarios. So that's me.
Hi, I'm Lindsay Forleo, another nurse practitioner on the inpatient team for palliative care here at Maine Med. I've been here, I think, for about 10 months now, so almost during my first year. And prior to being here at Maine Med, I did a palliative care nurse practitioner fellowship at Dartmouth-Hitchcock in New Hampshire. So happy to be here and excited to talk to you all today.
Yeah. So we thought that we would really start by, if anyone is willing to unmute for a second, we hope that this can be as interactive as possible. We do have a slide deck that we can fall back on, but we'd really like to hear from you sort of what you're hoping to get from this and what specific questions you might have, if any, so that we can try and address them as we move forward through the next hour or so. So if anyone has any particular questions, please throw them in the chat or unmute. That would be great.
Or just topics that you're particularly interested in, or areas that you've really struggled with patients that you're considering palliative care for, and parts of the conversation that might be challenging, or certain scenarios that are particularly challenging for you to navigate. Anything like that, please feel free to jump in. And if you don't think of it right now, that's okay. You can raise your hand and interrupt us during the presentation if things come to you while we're talking. Feel free to just jump in and ask questions at any time.
Great, thank you guys.
All right, well, let's just move forward then. So do you want to go over the objectives?
Yeah, sure. Yeah, so we're just gonna, we have a lot of objectives, so we'll see if we get to them all. That's why we can talk about anything, and but these are the things that we chose and to highlight, and but we could spend more time on one or the other if there's something in particular that you all are really interested in. But we're just gonna basically go over what palliative care is, the guidelines around heart failure in particular, and then advanced therapies with heart failure. And then we're going to talk a little bit about how to have these conversations and kind of structure around the advanced care planning documentation, and then how to begin to have serious illness conversations with your patients. And then we'll also talk about code status discussion, and particularly around ICD, like special considerations with patients with heart failure. It's a little bit more nuanced than other patients in terms of code status discussion. And then we'll end with just giving you the information around what qualifies for hospice for people with advanced heart failure. So the palliative care, most of you probably are aware of this, but it's always good to kind of go over it again. I feel like, so palliative care is it's a medical specialty that is focused on taking care of any patient with any serious illness, and that we can be involved, ideally at the time of diagnosis or early on in the diagnosis, and then follow patients throughout the progression of that disease. Palliative care does cover the entire lifespan, including the end of life, but it's different than hospice in that we can be incorporated into the medical team much earlier and throughout the progression of disease while people are still seeking treatment for life-prolonging treatments for that disease process. We're really focused on just improving people's quality of life and how they live with that disease burden, trying to improve symptom management, and then also just the emotional burden for the patient and the family and caregivers. Especially, this is particularly important also with people with heart failure. There is often a large caregiver burden for people who are caring for a loved one with heart failure. So we really focus on the quality of life of the patient, but also take into consideration the entire family. And then we are really multidisciplinary. We have nurse practitioners on our team, of course. We're here. We also have a PA. Chaplains are involved, physicians. We have social work. And we really incorporate all members of our team, all specialties, to be able to really support families wherever they're at, whatever their needs are, and however this disease is impacting their family's quality of life as a whole. So do you guys have anything to add to that I didn't say? No? Okay.
And I would just say the comment at the end, primary, secondary, and tertiary, that just alludes to the different levels of palliative care or where people can access palliative care. So primary palliative care is actually often done by someone's primary care or cardiologist or their generalist practitioner to sort of start these conversations. Secondary palliative care might be a palliative care specialist in an ambulatory clinic, and then tertiary is what you know us to be doing here, specialty palliative care providers in acute care hospital setting. So there are different layers to it also. So why palliative care in heart failure? There are many reasons for this. I think you have probably all witnessed that heart failure, especially advanced heart failure, can have a significant impact on a person or their caregiver or family members' quality of life. Everything from large amounts of medication or diuretic regimens or limited activity tolerance and having to sort of reshape where their limits are as that affects their quality of life. There can be large amounts of symptom burden, and we think of that not just as pain or shortness of breath, but also effects on appetite, depression, anxiety, any other sorts of visceral pains. Those are all issues that we hope to address in our patients to help them achieve an acceptable quality of life. There is complex shared decision making for these people, and whether that is around seeking different procedures or where they wish to spend their time, with frequency of hospitalizations, et cetera. We hope to address goal concordant care, meaning we hope that the care that we are providing for people is aligned with what they want for themselves. So our goal is never to imply limitations to somebody's care unless that is what they are seeking, but rather we understand sort of how much they're willing to go through or what their hope is to achieve with a certain procedure or intervention, and then align all of our expectations. And that's between family, patient, cardiology service, palliative care service. And We like to assist with advanced care planning, and Lindsay will talk more about that in a little bit. So that is, again, having conversations to prepare patients and families for the future, so we understand what their hopes are, where they wish to spend their time, who are the most important people to them. And there's actually studies that have shown that when palliative care is involved, that advanced care planning happens at a much more at an increased rate. So Dr. Hutchinson and Dr. Crispo of our team did a study here in the hospital, actually, with palliative care and heart failure teams in these patients. And they were more likely to have had some sort of ACP documentation or a code status discussion. There is a lot of prognostic uncertainty in heart failure. I think it is a difficult thing. People sort of have this roller coaster up and down of symptoms or hospitalizations, and families are often asking us, when is the time when we should start thinking about the future, or how will we know when as someone's disease is progressing. And I'm sure you've all seen patients be incredibly sick and then sort of bounce back and wonder how they're able to do that. So it can be hard to talk about prognosis when we ourselves are sort of uncertain about it. And then the importance of honoring what a patient wants for themselves as they approach the end of life. So where they have they thought about where they want that to happen, what would feel acceptable to them, what not. You know, do they want to be around their family? Do they want to be in the hospital? And there'll be more to come on that also. And I guess it's also worth noting that there is growing numbers of guidelines from major cardiology societies and palliative care societies that integrate both palliative care early in the disease diagnosis and trajectory. It really used to be focused more on end-of-life decision-making, you know, with respect to device management, ICDs, VADs, mechanical support, et cetera, or really a referral to hospice. But more recently, there's been an acknowledgement of the benefits of palliative care earlier in the disease for all of the reasons we just mentioned. This slide, I think, can be helpful just to think about the different trajectories of dying or of illness for people. You can see sudden death is on the top left there. That's really, you think of somebody who has an acute trauma, an acute car accident, and they're living their life, and then all of a sudden something really catastrophic happens or dramatic happens. A terminal illness is something more like a cancer diagnosis. The catastrophic event on the right, you can see that might be a stroke or a TBI, where someone is doing okay and then becomes acutely ill, and then they sort of plateau as time goes on. Frailty on the bottom right is perhaps someone who has dementia or Parkinson's disease, and they have this kind of slow, meandering downward trajectory. And then organ failure is really what we see in heart failure, where overall the trajectory is downward. However, there are all these bumps along the way, the roller coaster, like we mentioned earlier. So those dips where there is that downward inflection is where someone has a heart failure exacerbation or they're admitted to the hospital, and then they are able to get treatment for that exacerbation or have an intervention, and they're able to return, although never really to their prior level of functioning. There's always something kind of taken away from them with each event there. So when we think about prognosticating for these patients, this is some of the framework that we on the palliative care team use. We see patients with all diseases, so we can't be experts in all of them. So we rely on things like this to sort of help us talk with them and their families. And then this is really where this is really where we think about integrating palliative care early in the disease trajectory. So like I said earlier, there is consensus amongst cardiology and palliative care organizations for integration from diagnosis, and people are still seeking life-prolonging treatment. You can see that bar and arrow along the top. Our involvement with them may be less in the beginning, and then as their disease progresses, as they get sicker, as limitations become more abundant, and interventions become fewer, our involvement tends to escalate. So that is really what the ACC recommends there for palliative care involvement from the beginning. And this is a slide from the Journal of American College of Cardiology from the ACC guidelines. So like we said, there's just as the majority of initial heart failure management might be coming from someone's primary care or general cardiologist, and maybe not until they have advanced heart failure are they seeing a heart failure specialist. The same is true with palliative care. So most palliative care initially, primary, might be done from their general providers or their oncologist or nephrologist or cardiologist, and not until their disease becomes more advanced is the time to consider specialty involvement, either with complex symptoms or higher disease burden or caregiver distress. And the reason for that is not because we don't want to be involved with every patient from the beginning, because we do. The reality is that there are not enough palliative care providers out there. So there's, it does determine, for physicians anyway, it is a specialty fellowship that a physician needs to seek training for and become board certified. There's only about 200 fellowships across the country annually, so that's not very many people graduating with a fellowship every year. And there's something like one palliative care provider for every 20,000 patients living with a serious illness. So again, is just not the way that we can, does not provide access for every person. So if we could see everybody, we would. I'm sure you have heard us say, unfortunately, we will see them when we can or refer to ambulatory follow-up, but those are the reasons for it. It's just because really the workforce is not robust enough to support all of the patients that we would like to see. And again, interject anytime with questions or comments.
And that's true on like a national level, but that's definitely true within our team
Yes.
as well, where our team is a reflection of what's happening nationally. Yeah.
So what are some indications for palliative care referral? You can see there the ACC recommends stage 3, stage 4 heart failure symptoms, ICD discharges, recurrent hospitalizations, or refractory angina. There are milestones when palliative care referral is indicated. And I'm saying this as we said palliative care from the beginning, from diagnosis, but this is really indication for specialty palliative care, not the primary palliative care. So the milestones, like a person is now on inotropes, maybe going home on inotropes, palliative inotropes as they're often referred to, or inotropes maybe as a bridge to something else, to procedure, to VAD. LVAD is definitely one of those milestones where palliative care is actually mandated by CMS. Cardiac transplant is an indication, not a mandate like mechanical support, but certainly an indication when we think about the the life-changing aspects of a person having a major surgery and then living with a transplant. ICD implantation and TAVR, and oftentimes it's someone may be seeking a high-risk TAVR, but sort of depending on, there is a spectrum there of the patients that we will see based on their comorbidities. And other indications, again, significant comorbidities or high symptom burden, when there is complex decision making, when we see a decline in someone's functional status, that can be dramatic. Maybe it means they are no longer able to live at home. Maybe it means they don't have a caregiver who's able to help support them in the community anymore. And then patient preference, whenever a patient or family asks, then we show up. And policy, sort of mentioned this, but for DT LVAD accreditation, there is a CMS mandate that palliative care is involved and meet all of those patients pre-implant, and then we follow them throughout their hospital course, their implant course, and then post-implant as well. These are often patients that we see whenever they're admitted to the hospital, readmitted, but we also follow them more peripherally, usually in the community. But if their disease is progressing or there are any issues, then we are more actively engaged with the VAD patients who are living in the community, and we see them depending on the need when they come for clinic visits. It's been really hard lately because the clinic being over in Scarborough for the last year or so, but we're glad that they're now moving back to the MMC campus so we can reconnect with these patients that we were not able to see. You can see the recommendations for palliative care involvement there from ISHLT, Heart Failure Society of America, and American Heart Association. And then at Maine Medical Center, again, indications are for anyone seeking an LVAD. We are part of the selection committee, and our assessment and consultation is necessary for them to be approved or considered as an LVAD candidate. And then for ECMO. And I think that's also just a comment that of sort of an example of our involvement of patients that are seeking life prolonging therapies, that that in ECMO and transplant are certainly offered to people who are looking to extend their life, and not patients who are looking to necessarily place any limits on their care. And those are clear examples of where we are also very involved with those patients and their families. So why with mechanical support? Well, it's mandated, like we said. It's an automatic trigger in Epic with an ECMO order set. So someone would have to unclick that box if they did not want our involvement, but otherwise it is an automatic trigger. The reason being, patients and families are often feeling incredibly overwhelmed, trying to make sense of what is happening. There is definitely complex decision making when it comes to any type of mechanical support. ECMO, of course, comes with a high mortality rate. So we are there to support patients and families from the beginning, and not just if they are dying and we are out of options for them. There's nationally a lack of community resources for VAD patients. So as you know, it's incredibly specialized, and there are not nursing homes. There are not a lot of home-based support teams, nursing teams, hospice teams that are comfortable or familiar with that. And so patients and families really have to become the experts on it. And unfortunately, a lot of the support services that we might offer to patients living with other diseases are not available to them because of that unfamiliarity or the discomfort. And then the complexities of dying with a VAD. It's, even though we have this conversation pre-implant, that it is different from someone dying who is dying more naturally or without mechanical support. That is often not the thing that they are going to be remembering. They are remembering everything and processing through that they're enduring at that time, and getting sort of worked up for the implant and focused on extending their life. And so when people have complications, or they have really decided that it's no longer supporting an acceptable quality of life, we revisit talking about what it's like to die with a bad, which brings significant psychological, spiritual, existential distress for patients and families, feeling like it's somewhat of an active process. And then again, there are many hospices that, because of the unfamiliarity, are hesitant to accept someone for home hospice. We do have a good relationship with Gosnell House, so we've had several patients admitted to the inpatient hospice prior to turning off their bad. We've had patients that are at home, but it takes an incredible amount of collaboration and coordination between a hospice agency, oftentimes us on the palliative care team, the heart failure team, and the VAD coordinators to be sure that it is something that runs smoothly and that patients and families have a positive experience through that time, because it can be a very hard end of life for some people. So now, Lindsay, we'll talk about
We'll just pause and see if anybody has any questions. That was a lot of really great information. Does anyone have any questions about ads or what Katrina was just talking about before we switch gears? Okay.
All right.
So I pause.
Yeah, that's good.
We do a lot of pausing in palliative
Yeah.
care.
Always good to pause and let all that sink in.
Or Andrew, if anything is put into the chat, we of course can't see
Yeah, we
it.
can't see it.
So please let us know if there's anything there.
Okay, nothing's come up yet.
Hi, my name's Jeannie. I'm not sure if this is coming through. Can you hear me?
Yeah, we can hear you.
Oh, great. I'm a nurse practitioner here in cardiology in the outpatient setting. And there's a couple things that I would like to mention. The first is there are a lot of elderly that are in end stage CHF that are not with the heart failure clinic. And then there are a lot of patients that really want their ICD turned off. And this is something that I find that our EP team not necessarily has the knowledge here in the office. I mean, they're brilliant, but there is that ethical decision, and many of them, from my experience, are not comfortable turning off the defibrillator without an appointment, or it gets to the point that the man or woman that wants to do this or the family does it, and many of the docs want them to come into the office. And we know as caregivers, that's not always possible.
That's a really, that's such a, thank you so much. We,
Thank
all of
you.
us, we all work a lot, you know, we're all inpatient. And so it's really great to get perspective from what's happening in the outside world, because, you know, we see people for this like brief moment of time and forget about what it's like and like the rest of their lives, the majority of their lives when they're home. And we do have an outpatient clinic, but it's not nearly enough. We don't have like, it needs to be probably 4 times as big as it actually is right now to be able to help see the patients that you're describing, because I do think that that is an excellent place for our team to be able to be a support for the providers and the outpatient to try to help negotiate those discussions and you know, help, you know, provide this support for like what you just named, the ethical dilemma that a lot of people feel about turning those devices off. So I really appreciate that. And I think that, well, we can talk about it more a little bit later, I think, when we talk about code status, but I think that we would all be very open to brainstorming about ways that we can just create some sort of support, like either just having, like doing like what we're doing now and talking to the outpatient team about having a conversation about what people feel is most distressing about turning them off, and just kind of talking it through. with people, the providers that you work with. I think that might be a good place to start. But we're happy to do that because it's a huge quality of life piece for patients at the end of life. And it's incredibly distressing to have those go off when somebody is trying to die or dying and who have chosen, maybe hospice or want to die at home and want to have this, dignified, peaceful death, and then the ICD is going off. It's a big, not a great scenario. So yeah, we'd be happy to talk with you more about that.
Wonderful. And I'll just make one other point is that over time in the end of life setting, the pacer cannot get through, I'll say it, dead myocardium. And so there's quite a bit of a knowledge deficit regarding families that wish to turn the pacer off. But I know from experience that there comes a point when the heart muscle would never be receptive to an electrical stimulus to work, and it just prolongs life not too much longer. So I think that that's a piece of education that we need. And finally, many of my team, when I want to go through some, like a post form or having docs understand, if they visualize somebody passing away or reading in the paper about mortality, that's the signal. And some of us have learned that with the class after a conference, but I think that the knowledge deficit is quite strong.
Yeah.
And do you mean about pulse form specifically, Jeannie, or do you mean the conversation that's happening when a pulse form is being completed, or all of it?
All of it.
Yeah.
I mean, this is I'm more upstairs with the general team, and I think it's a bit easier a lot easier for the heart failure team that has had quite a bit of expertise and experience. And I find by the time they're referred to the palliative care team, most of them only live a week. And I feel like the earlier would be so much more effective and comfortable for patients.
Thank you for saying that.
Thank you. Yeah, we agree. We agree. Yeah.
And I did say finally, but the other point is that I think education here, and I'm the representative for CME and gathering classes for NPs. I do believe that would be an excellent educational opportunity, and I can help arrange that here.
Great.
Yeah, that's great. We'd be happy to do that, to work with you on that.
I'm all done. Thank you.
This is what we wanted, was to hear what's really happening, like in real life for you all, because we're coming from our perspective, but we don't really know what you're facing and what's stressful for you.
Right.
So I'm really glad you brought all that up.
And I'm a former hospice and home health nurse, and so there's a certain comfort level, but it's not universal at all.
Yeah.
Thank you for your time. I'm still listening, but I will just listen for a while. Thanks.
Thank you.
Thank you. Anyone else have anything to add? All right, so moving on to the topic of goals of care, I think oftentimes when we get a consult here for inpatient palliative care, this is one thing that is, I think, often requested by many of the specialty teams, especially, I think, the heart failure and the cardiology teams. So really, what is goals of care? When patients are faced with a serious illness, it is helpful for the patients to make medical decisions based on kind of some factors. So things that we often explore with our patients are, what are their understanding of their illness, and do they understand the risks and benefits of treatments that are being offered or recommended? and what are their goals and worries for the future. If they have a specific goal that they are hoping to achieve or accomplish, and we think that a treatment may or may not get them to that goal, I think that is oftentimes how people will make medical decisions. Also the same with worries if they have a specific worry. And oftentimes we're talking with patients about what are the trade-offs? What are they willing to not go through for more time to prolong their life? That is also really important for us to understand to help people make decisions about their health and their health care. So what is it that clinicians can do to play a role in helping people make medical decisions? I think we as a palliative care team often are asked to share prognosis with our patients. I think that is something that both us specialty palliative care clinicians can do, but also clinicians on primary care teams or specialty teams. I think what Kat alluded to earlier is that we see people with all different diseases and illnesses. So sometimes it is hard for us to really prognosticate, especially time-based prognosis. So oftentimes we will go to the primary care team or the specialty team to really get a better sense of, what is your understanding or what is your sense of how much time this person may have or what their trajectory will be going forward. So that is something that can be shared with the patient prior to even us being engaged. Also, asking really patients what is most important to them. I think, again, that is something that can be asked prior to our involvement. So, we can get a better sense of, where patients are coming from before we meet them. And also, after we get a sense of patients' understandings, what is most important to them, what are their trade-offs, sometimes we do make a recommendation that is grounded on our patients' values and priorities. I think there's a lot of talk about shared decision-making. Sometimes it is helpful to make a recommendation to our patients. We are, medical experts, and we have a very good sense of what risks and benefits are to certain interventions and whatnot. So that can be something that is very helpful to patients and their families.
I would just add, is that okay, Lindsay?
Yeah.
Just that this is incredibly important in heart failure because it's such a highly intervention-driven process. There are so many things that can be done or tried at different stages of the disease, and so when patients are living for many, many years and become comfortable with just always asking their cardiologist what's next, when there are no other treatment options, they still need to know from their cardiologist what's next. And that what's next, might be transitioning to hospice, but they need to hear that as well. And so, we can step in and talk about that, but that often needs to be, a shared process with the cardiology service because of that history. Of just being so, just having such a highly medicalized life for so long, people really become dependent and feel, like the cardiology team is kind of their lifeline. It's kept them going for so long. So when we get to this point where we're really talking about goals at the end of life, we also need that support. So. Does that make sense?
Yeah.
Okay.
I just wanted to add, I think from the inpatient side, I think that's sometimes one of the things that we struggle with is we're so conditioned to push. And at what point, what is that trigger that finally is like, all right, we really need to get palliative care involved and what their prognosis looks like. I'm drawing a blank on the statistics now, but if you've had, a few heart failure admissions, your mortality rate significantly increases at that point. And it's really hard then to kind of adjust and change gears. And that's where we really rely on you guys heavily. And then just because I'm talking, the other thing that I feel like as an inpatient provider that we sometimes don't do a great job of talking, at least for myself, is addressing code status. So those are just a few points I wanted to make.
Yeah.
Thanks, Andrea.
Yeah.
And I think we can jump, a little bit to talking about prognosis and some of the things that we share with patients. Before we do that, I just wanted to share with you, this is the Serious Illness Conversation Guide. And this is really a framework for not only specialty care providers, but really, for primary palliative care, really anyone that is seeing a patient and feels like it's important to have a conversation about what is ahead with someone's illness. This is a framework to follow, and really someone can actually use, this guide top to bottom to have this conversation, ask questions. You can find this on Google. And this is something I think that we often use, to help facilitate our conversation. So, really, it starts with asking someone their permission, is it okay if we talk about this? And then discussing their understanding preferences, sharing a prognosis, and then after sharing a prognosis, allowing time to explore someone's emotion after they hear sometimes very difficult news. And then exploring some of the things like goals, fears, worries, critical abilities, trade-offs, how much has family heard, or how much does family know about what their priorities and wishes are. And then summarizing the conversation and sometimes making a recommendation, letting people know that we're going to continue to support them along their journey. And then making sure to document the conversation is really key, especially I think if if someone has had a goals, the start of a goals of care conversation, especially I think for us, meeting patients for the first time, it's really helpful to know, what has been discussed so far. Has the provider explored understanding of illness? Have they shared a prognosis? That's really helpful information for us to know, but also kind of anyone that's going into the chart to know, what has been explored with the patient so far. So again, exploring understanding of illness. Some things to talk about are, do they know how serious the illness is? What are their perceptions of, whether or what the trajectory is? Is it progressing? Is that something that they understand? And then what are their expectations for the future? So there are different ways to discuss prognosis and provide prognostic understanding. I think oftentimes we think of a time-based prognosis, how much time someone has, days to weeks, weeks to months, months to years. But you can also share prognosis in different ways. So a functional prognosis, or sometimes it's unpredictable, and that is even something that you can share with patients. So a functional prognosis may be that, we worry that this is as strong as someone is going to feel. And that is a way to kind of set a conversation up. So if someone knows, this is as strong as I'm going to feel, it might help them make decisions going forward of, how much they're willing to go through, or what interventions they might think about pursuing. And then also sometimes prognosis, it's difficult to prognosticate. And we have to share that uncertainty, but also knowing that to share that there is a possibility that the disease could worsen very suddenly. And I think we see that a lot with patients that have heart failure that is advancing, that, you know, one setback could really, you know, their condition can worsen really quickly. So it's important for our patients to be able to prepare for that. So we know, you know, if they were to get much sicker, you know, what are they hoping for and how can we guide them going forward? So I spoke a little bit about responding to emotion. This is something I think that we all do, you know, a lot when we are seeing our patients. And, you know, yes, we are, you know, exploring understanding of illness and, you know, providing, you know, medical information and exploring goals and values. And we're also responding to emotion through our conversations. So these are kind of ways that we do that. There's a nurse mnemonic that we use often, so that we can, you know, name the emotion, further explore how someone's feeling, you know, support them, making sure that they know that, you know, if they, you know, if they share something that, you know, if they share their fears, their worries, they know that we are there to support them throughout this, so that they feel like that we are not abandoning them. I spoke about this, that, you know, it's really important to document your conversation. I think, you know, we do that in our notes. But again, if there is a start of a conversation that happens even before palliative care is involved, it is so helpful to write that in your progress notes. You know, sometimes you can see goals of care, you know, as on kind of that problem list, and you know, you can comment on that underneath and just say, you know, what is the conversation that you had? What were the outcomes of that conversation? You know, sometimes we say that the conversation is even more important than the paperwork. So yes, someone can have an advance directive, but sometimes it's more, the conversation is more nuanced. So really kind of putting out there what that conversation was about can be super, super helpful. And then this is, in terms of advanced care planning, I think these are ways that we can see whether someone has advanced care planning documents in Epic. So the two forms that are most often completed and scanned into the computer are advanced directives and living wills, and also post forms.
And so those are hyperlinked. So if you see where it says code status, Taylor has ACP docs. If you click on that, it will open up that next screen, which are then hyperlinks to the documents that are scanned in. So you can view them.
Yeah. And then, you know, the two documents again that we really help fill out with patients are advanced directives. And, you know, there are kind of two parts on the advanced directive. One is where patients can fill out who they would like to be their medical power of attorney. So who is that person or people? You can also have two alternates on there. So who are the people that a patient would want to make decisions on their behalf if they weren't able to make decisions for themselves? And then also, you know, what are their, what would they be hoping for if they had a terminal condition, you know, a late stage Alzheimer's dementia, you know, whether or not a feeding tube would align with, you know, what they would want if they did have a terminal condition. What are their thoughts about pain relief, symptom management, if they're really sick? Is that something that they would like to focus on? So, and really advanced directives are guidelines for us. You know, it's not something that, you know, people can also, you know, have, you know, something selected on their advanced directive, and we still have to have, you know, not everyone is at kind of this stage where their disease might not be recoverable. So, again, these are guidelines for us to use, but sometimes, the decision is a little more nuanced than what exactly is written in their advanced directive. And then I think Jean talked about the POLST form, which stands for a physician order for life-sustaining treatment. This is a form that we complete with patients if we know that, their time is limited going forward and they have very clear goals or clear limitations that they would like to place on their care, whether or not they would be willing to undergo CPR, whether or not they would be willing to go to the intensive care unit, have mechanical ventilation, whether or not they would want to be rehospitalized or not going forward, or if they would like to focus on comfort and not come back to the hospital. Oftentimes, that is when we're selecting comfort-focused treatments, and that is really when we start conversations about hospice services, so that people are supported in the community when they decide that they no longer want to come back to the hospital. And again, this is a physician order. It's a provider order, so it can be signed by a physician or an APP, so both NPs and PAs. And it should go in their medical record, and it really should be followed when patients are out in the community and also here when they are back in the hospital. Any questions about goals of care, having those conversations, or any of the advanced care planning documents?
I'm realizing that we're
Yeah.
loaded up the time. So yeah, so I just want to appreciate that this was like the code status discussion is an important topic, and I feel like we could probably have a whole another hour just talking about this. But Andrea, you brought that up, and I think that it's particularly complicated with heart failure with patients who have advanced heart disease. Because of the issues we've already mentioned about, oftentimes even if patients request being DNR, we reverse it for certain medical procedures. Sometimes it doesn't get changed back. Sometimes that results in multiple conversations from multiple people who explain things in very different ways and completely confuse people as to what CPR actually is. It gets really hard when it's important. It's really difficult because we need to be having these conversations throughout the disease process. And yet, especially when they're in the hospital, so many different people can come in and talk about it. People get really confused. And so it's just the nature of it. I don't know if there's any way to solve that or change that. It's just the nature of being in the hospital and having advanced heart disease. And then also a lot of times patients have been resuscitated before and it's been successful. And so it's often, if you're bringing it up again, it's really hard for people to understand that even though it was successful in the past, they might be at a new place in their heart failure. Their heart failure might be more advanced at this stage, and it might not be successful at this point, even though it was in the past. And so that's a very hard concept for people to get. They also, like I mentioned before, they have really long-term relationships with their cardiologists. So a lot of times, even if we're asked to go in and discuss code status, we often get put in a position where the patient or their family really need to hear it from the cardiologist. Like if the team is at a place where they feel like CPR is not going to be successful with this patient and everybody feels uncomfortable with thinking about doing chest compressions or trying to do any kind of cardiac resuscitation for a patient, and we're asked to go in, we can have that conversation and explore where the family's at with that. But it often is necessary for the cardiologist to actually give a recommendation or to say, yes, we're at the point where there's no other interventions that we can offer you, and we do not think that if your heart stopped, we'd be able to get it restarted. And often this conversation is really based on we have to think about like what Lindsay was talking about is in terms of functional prognosis. So so it's helpful to talk about with patients how they're functioning now, and that might be as good as it gets. And if they went through CPR, even if we were able to get their heart restarted, they would not return to that functional state that they were in previously. And so that's another way that's really helpful to talk about it in terms of function, especially with heart failure, as people lose the ability to do their regular activities. And I feel super pressured because I know it's 8 o'clock and people probably need to go. I feel like the whole ICD and pacemaker consideration is really important. And as Jeannie mentioned, it's incredibly complicated. But what I will say again is just that turning an ICD off is a issue around quality of life for the dying process for people. So, you can think about it as any other quality of life making decisions, such as using, pain medications or opiates for dyspnea. This is not something that is it's not a great way to die. For people to have their ICD firing, and the discussion around turning off an ICD really needs to happen before the ICD is placed. So those conversations would hopefully, and they are recommended to happen before the ICD is placed, for whoever's placing the ICD to also talk about, this is when we're placing it and this is when we turn it off. And so patients know that these can be simply turned off, and when you would do that in the trajectory of this disease process of the heart disease. So those conversations really need to be happening when the ICD is placed, and that's for the benefit of the patient and the family, who may not remember it later, but at least they can recall, yes, we did talk about this. And it's also important for the cardiologist who's placing it, for their own learning and to be able to say this, this is when we turn it on and this is when we turn it off. So there is a time to turn these things off. They're not there forever and ever. And there is a time to turn these off, and that conversation needs to happen early. Pacemakers are a little bit more complicated depending on if the patient is pacemaker dependent or not. In terms of symptom management when those are turned off. But I think that typically the more complicated one tends to be the ICD, because it feels like people feel like they're doing some sort of, it feels very active, as if you're withdrawing, taking somebody off of the ventilator, but so it feels more dramatic, but for us, it isn't that dramatic because we do this sort of thing all the time, but I understand why it is for people who don't do it all the time. But it is the responsibility, if you're putting it in, the conversation needs to be had at that time, that this is also when we will turn it off. So I feel pretty strongly about that. So.
And to reiterate what Jeannie said earlier, is that the pacemakers eventually will not capture, right? So
yeah,
pacemakers do not need to be deactivated.
Right.
ICDs at some point should be deactivated.
Yeah. But if people do choose to turn off a pacemaker, which sometimes they might in certain situations, and they're pacemaker dependent, you just need to be prepared, or whoever they are, they need to be in a setting where their symptoms can be adequately treated when that's turned off, if that happens. But that doesn't happen nearly as frequently as the ICD. The ICD is way more common. So we're just going to stop there. I think it's because it's past 8, and just see if there's any last questions or things that comments people want to make.
No, thank you very much, ladies. That was very helpful.
You're welcome. Thank you for inviting us.
Yeah.
Sorry we weren't able to get through everything, but
Yeah.
enjoy talking about this stuff.
Yeah.
And I'm happy to do it, and happy to connect with anybody who'd like to talk more either offline or in any future sessions like this.
Okay, perfect. I'll be posting the slides for those that are listening onto our Canvas platform for so we could review further.
Great.
And I would just enjoy one of the facilitating collaboration with us here. There's like a 99% chance that it's the NP that's getting the permission from a patient or consent to put the ICD in.
Is that part of the conversation of when you turn it off, when you would turn it off?
No.
Yeah.
I mean, not in my experience.
Right. Yeah.
Like never.
Yeah. Okay. So that would be a great thing to incorporate. Like, I don't know if you have like if there's like a structure, if it's a consent, I imagine that it's pretty structured in terms of what you review.
And it's not about getting it turned off.
Yeah. Yeah. So that would just be like that would be a pretty, you know, I don't think it would take a lot of time to talk about that, but, you know, maybe 5 minutes or less, but a hugely important part of the conversation in terms of the patient's understanding of the device, what it's meant for, and what, I mean, I'm sure you do that, but I don't mean to be dismissive of that at all, but that would be really helpful down the line when we're consulted, you know, so it to not be a shocking thing for us to ask about that, because a lot of times patients have no idea that it can be turned off.
Exactly.
Don't even really understand what it's there for a lot of times. And maybe they've had it for years and years and years, and they've forgotten those early conversations, which is often the case. But
yeah, is there a representative from the team that's ready to have a connection with our outpatient practice that's not necessarily Hartford?
I'm sorry, that's not necessarily what?
Heart failure. I mean, there's a lot of that on ICD on the first floor. There's a lot of heart failure and ICD on the third floor.
Yeah.
yeah,
I mean, our team would be happy to, you know, network or collaborate, however that would be helpful. And whether that's in terms of a direct consultation, or whether that is some sort of guidance or, you know, recommended language that we can offer to you to use in your consenting or whatever. Happy to talk more about that if you want to.
Yeah,
that's
that's great. Even just say in service for an hour with the MPP team, that would help a lot.
Absolutely.
Yep, definitely.
Yeah, that
Thank
would be easy to do, and we could help you with like outlining a strategy of how to do it, how you want, what feels right, you know, what feels comfortable for everyone, and in terms of how to start to incorporate that kind of language and discussion.
Wonderful. Who would be the contact person for me on your team to come?
Yeah. I mean, it could be me. I only work part-time, so I'm always hesitant to do that because I don't always check my email if I'm not at work. But it could be me, and yeah. So
Andrea, what if we sent you our 3 emails and then you can send it out to the group? Would that be okay?
Yep.
Wonderful.
Okay.
Yeah.
We'll do
Thank
that.
you.
Sure. All right. Well, thank you everybody so much. And again, thanks for asking us to be here. It was a real pleasure, and hopefully we will work with you all again in the near future.
Okay, thank you guys.
Thank you.
All right, thanks. Bye, guys.
Thank you so much.